I'd like to say Pojadi Gamarua, g'day everyone. How is everyone this morning? Great. As I understand, you're all around the country, and then also we have people we're streaming to all around the world, which is great. And we're in Sydney here, which has one of the most beautiful, if not the most beautiful harbour in the world. Here where we are is on the land of the Gadigal, one of the 29 clans of the Eora Nation. So this is where the CBD is. If we were in a traditional canoe, it would be called a Nawi. A bark canoe is called a Nawi here in Sydney. If you're paddling out from this side and looking across the other side of the coat hanger or the bridge, you would see that that's Camaragal country over there, where the suburb of Camara is named after. On the right, as we're paddling out, if you look at the Opera House, that area there is called Jabbagali, and traditionally there was middens there. The middens were taken and they were used in the very first building. So if you have a look in Macquarie Street, in the Mint, and look at the mortar, also down at the Rocks, where there's the older warehouses, and in Argyle Street you'll see specks of shell in the mortar. The Rocks is actually called Tullawallada, that's what it's called down there. Traditionally, whales would come in here as their migration up and down the coast, and they would come in here with the little calves and they rest down at Darling Harbour. Unfortunately, they didn't do that these days. They would go down there, and that's called Gomera, down there, Gomera. As we're paddling along, we turn west, we're heading inland. Beside Gadigal, the next one is Wongal. That's Wongal country. That's where the Olympic Park is. If you look at the other side of the river, that is Wallamadigal, where Bennelong is resting. Bennelong, obviously, where the Opera House's point is named after Bennelong, where he had a place there previously. And Bennelong had a strong Camaragal woman for a partner. Does anybody know what her name was? Starts with B. Barangaroo, yes. As we keep going, we see there's a city of Parramatta. What's Parramatta named after, the clan out there? Barra Marigo, Barra meaning eel. And there's a whole creation story about Sydney Harbour and the waterways being created by a giant Barra. And Barra's just resting off of East Balmain. There's a little island there called Memel or Memel, Eye of the Barra. It's an important place where clans would meet. And it is transitioning back to the land council. It's so important that these places do return. What I was going to say is, look, I'll get you guys to look up something on your phone. I think it's pretty important to look at our interaction with the world, because we did trade with sea cucumbers up the top. Huntingbird Manuscript Vatican, and those at home, you can use your computer and Google. I'm sort of judging your skills against kids too. Huntingbird Manuscript Vatican, you'll see a very familiar face. Another one of our totems, like the whales are a totem of the Gadigal, and it's also other clans, tribes and nations would have it. And then across the other side of the harbour we have a whale engraving over there on Ball's Head. Now, what have you found? You find a cockatoo from the 13th century, the Vatican, obviously. So very important to understand this. We made this point with the Chinese ambassador and the consuls about 18 months ago, where we celebrated a guy named Gough Whitlam going over and re-establishing relationships with there. One could only imagine what the world would be like if we were allowed to continue that relationship, which was stopped about 100 years ago with the Macassans, the Indonesians and the trade. And there was some migration both ways. There has been some recent stories, and I know there's some documentaries being made about Aboriginal people actually migrating to Indonesia and with the Macassans and that. It's a great depiction of a cockatoo, because the cockatoo has attitude, doesn't it? Yes. What are cockatoos like? Everyone says noisy or loud. They are loud and noisy, but they're very cheeky, they're very mischievous. And they will, if you upset them, they'll come and chew all your stuff, won't they? Yeah, so you've got to respect them. They're part of totems too. Another bird that we see out here that's been somewhat marginalised, it's had a similar journey to Aboriginal people. It's got white feathers, black tail feathers, a long neck and a long beak. Yes. It's called the sacred ibis, sacred in Egyptian culture too. It's not its fault. It has a relationship with Aboriginal people because it's been dispossessed the country. It's a wetlands bird. It's had to come and live in the city, and it's been marginalised and blamed for its situation. The same as Aboriginal people when we moved to the city too. So it's important we think about these things. What I was going to say too, that it's important to remember that there's a lot of hurt out there, a lot of trauma, as you know. The last few years has been quite hectic, and we had the whole world locked down at one stage. It's important that we do take a moment's silence to pay respects to our ancestors, pay respects to Mother Earth, pay respects to those who were lost through the pandemic. Remember, they're not just numbers, they're people with their own names, their own families, their own communities. And also, we need to, as I said, Mother Earth provides us with everything. It's so important we respect her. So if we have a moment's silence to pay respects and a moment of our reflection. We have three beautiful waterways that are boundaries of the Eora Nation. We have the Hawkesbury, Nepean and Georges. On behalf of Metropolitan Local Aboriginal Land Council, we welcome everyone here from around the country, and also to stream where we're streaming around the world. Acknowledge all the First Nations around the country and around the world that we are streaming to, and their culture, their history and their elders. We'd like to make everyone have a wonderful stay here, safe journey to your home, to your family, loved ones and community. We are going through very tumultuous times in the world, one might say, that is causing a lot more trauma and a lot more self-medication, one might say. I'm sure that's going to be happening in November and in January too, when you think about it. The world's in some very dark places, one might say. When you look at the news at night, I don't like looking at the news because it's very sad how we treat each other, and we're supposed to be the intelligent species. One might say, is that really true? Yes. We should have a bit more love in our hearts instead of hate, and we should be able to talk to each other and have those tough conversations that we need to have. I'll leave you with some of that wisdom from Aboriginal people and that. Let's all work and walk together. Thank you.
Welcome. My name is Michael Farrell. I'm the Director of NDARC. Thank you, Uncle Michael West, for that very warm welcome and reminder of the times we're in and the welcome to this event, and welcome everybody. I'd also like to extend a warm welcome to our keynote speakers, Professor Sir John Strang from the National Addiction Centre in London, Professor Matthew Hickman from Public Health, Bristol, and later today, Professor Jürgen Rehm, who will be online from Toronto. This is the 38th year of NDARC and our symposium, big symposium. I hope you will all spend time. We were very keen to make sure that it was as much in person as possible coming out of COVID, and that we get the opportunity to see each other in person and share things and hopefully create new collaborations. I hope you will enjoy it. And I would like to now hand over to Carolyn Paterson, who's the Assistant Secretary in the Alcohol and Other Drugs branch of the Australian Government, who are also key funders through the prevention programme of all the national research centres. So over to you, Carolyn.
Good morning, everyone. It's a pleasure to be here today and to hear about the great work being undertaken, and I would like to thank Professor Farrell and everyone at NDARC for putting on this symposium. I'd also like to take the opportunity just to acknowledge all of the work that you all do as well, researchers, service providers, treatment providers, those with lived and living experience, civil society and others do to minimise the harms of AOD. Today's session is a really great opportunity for us all to learn about some of the current research, treatment trials, and also some of the global interventions. We've got a pretty impressive team of speakers today from across the world who bring a wealth of knowledge, and it's going to be great to hear, so we're going to get straight into it. But I would like to note we do have Slido So please put your questions up for the end of each presentation. Our first presentation today, using linked cohorts to examine population-wide effects of opioid agonist treatments in New South Wales, will be delivered by Scientia Professor Louisa Degenhardt, who's the University of New South Wales Scientia Professor and NHMRC Senior Principal Research Fellow and Deputy Director at NDARC. So welcome.
Thanks very much. Good to see you all here in person. My talk is going to be short, brief as I can make it, but I have a lot to say, so I might go a bit over time. Sorry. My first thing is I'm going to be talking about a body of work that we've been doing over the past 15 years, and it really has been a group effort, and I really want to acknowledge all of the people who have been involved in that group effort before I get into the talk. Particularly Nikki Jones, Natasha Gisev, Michael Farrell, and Sarah Lani. But there's a big number of people who've really been involved in this effort. And we've been working on this gradually over time to really develop this body of work. I can't see those slides, just so the people, the IT people know you can't, yeah. Anyway, thank God I printed out my slides. So some of you will be very, very familiar with this, and some of you will not. So I just thought I'd do a quick intro in terms of what data linkage is and what it can help you do. So basically it is linking different administrative data sets together, and what that can do in countries where this is feasible is allow you to look at population-wide impacts of a range of different things. It doesn't have to be looking at impacts of interventions. It can also be more descriptive. But what it allows you to do is, in a very cost-efficient manner, look at the impact of interventions, if that's what you're focusing on, to look at rarer outcomes, to look at specific time periods within treatment and after treatment, and to look at subpopulations that really, if you were trying to do a randomised controlled trial, you would never be able to get the funding, and it wouldn't be feasible to undertake those studies in terms of the costs that would involve. It really involves, you need to have information on name, date of birth. You have to have good information on both of those things. And one of the other things when you're looking at potential impacts of interventions is you need to use statistical approaches that really allow you to adjust for potential confounding, because you're not actually undertaking a randomised controlled trial if you're looking at the impact of an intervention. And this is where, you know, the crucial role of statisticians and biostatisticians is really important in this sense. So we have used data linkage over the past 15 years, as I said, to look at a range of outcomes. So I've focused in this first thing around looking at mortality among people who are opioid dependent in New South Wales. And the reason that I focus on this one is it's a really good example of a very rare outcome that you would never be able to study in a randomised controlled trial. Well, I mean, you can, but you will never be powered to look at the potential differences. And you would never be able to look at differences in risk in a randomised controlled trial for specific periods within treatment and out of treatment, nor would you be able to look at that within specific subpopulations. So just to give you, sorry, I'm one slide ahead, you can't tell on this. Okay, so for many of you will be familiar with this, but some of you may not. But in New South Wales and in many other states and jurisdictions in Australia, People who are opioid dependent have relatively good access to opioid agonist treatment. It is not perfect. There are significant issues, but it is much better than it is in most countries in the world. I just wanted to give you a quick summary of some of the things that we have found in the very early work that we did, and that was particularly involving people such as Sarah Lani and Natasha Gisev, looking at what is the engagement or the contact with people who have a history of opioid dependence when we look at engagement with OAT. And what we found was 3/4 of people who had ever entered opioid agonist treatment had had some engagement with the criminal justice system within a 10-year period. They accounted for 13% of criminal court appearances within that period. 4 in 10 had at least one episode of incarceration between that roughly 10-year period. And the costs of incarceration of this cohort within that roughly 10 to 12-year period was over $3 billion. This is one of the ways in which we can demonstrate the ways in which we can think about how do we reduce costs and negative impacts, both for people who are opioid dependent, but also in terms of the system costs around these massive impacts of incarceration. What we also demonstrated was that if people were in opioid agonist treatment, both within being incarcerated, but within after they were released from incarceration, their risks of dying were massively reduced. And in work that was led by Natasha Gisev, not only was the provision of methadone and buprenorphine when people left prison cost effective, it was also cost saving. So not only did you save lives, but it was cheaper in a global way in terms of the costs. So I'm going to move on now to the next iteration of this linkage, which is called OATS, or OATS 1. And Nikki Jones has really been a key figure in this work. So we were funded by the NIH, and what we showed, it's probably not going to surprise some of you who are very familiar with this population. Median age just over 30, 2/3 men. Aboriginal and Torres Strait Islander people were massively overrepresented in this population, so 1 in 4. Most were in a major city, but it's pretty similar to the proportion of people who live in a major city, but very, very high rates of acute healthcare, both in terms of emergency departments, hospitalisation and outpatient mental health treatment. Sorry, Chrianna, this is your slide, and I know it's great. I'm just going to go straight to the end. So this is work that was led by Chrianna Bharat, looking at what are the factors that impact on retention in opioid agonist treatment. So the thing that we're really focused on is we know that there are real benefits around retaining people in either methadone or buprenorphine. So one of the things that Chrianna did during her PhD work was to look at what factors improved retention in OAT and what predicted poorer retention. And this is looking at the entire population of people who have ever entered OAT. So there were a few things that were probably not surprising. So people who enrolled in buprenorphine were more poorly retained versus methadone, but that is improving over time. People who were younger were more poorly retained. People who had serious mental illness were more poorly retained. But what we also found was the way and the people and the setting in which treatment was being provided also impacted retention. So people who had more experience in prescribing OAT were more likely to have people who were better retained in OAT. People who were prescribed within justice health settings were better retained in OAT. And surprisingly, people who had other substance use disorders and mood disorders, so depression, were better retained in OAT. So some of the other questions that we looked at in this particular linkage were looking at what are the characteristics of people who prescribe OAT and what are the trends in OAT prescribing. And one of the important things, and this was work led by Nikki Jones, was really demonstrating the fact that what we are seeing is an ageing of the OAT prescribing population, that people who are entering OAT prescribing are prescribing fewer clients and are more likely to be dropping out of prescribing quite quickly. And this is not something that is a shocking finding for people who are working within the Ministry of Health, but really to be able to document that in a systematic way. We've also looked at risk periods for adverse events, both within treatment, so during treatment induction, when people are in longer term treatment, when they leave treatment, and then when they're immediately leave treatment and then longer term, looking at injection-related injuries and diseases, overdose and suicide, all demonstrating that OAT has a real benefit in the long term, but there are specific risk periods when people are starting on treatment in the first weeks of treatment, and particularly when people leave treatment, the first 4 weeks when people are leaving treatment. So there's a real need to think about both of those periods as particular risk periods. The other thing that we've looked at in terms of looking at newer methods is, is there a real benefit in using new methods in terms of, deep learning methods around predicting retention over more traditional statistical methods? And this was led by Chrianna Bharat. And I hope I'm not mischaracterising this, Chrianna, but the short answer is no. So really thinking around how do we really harness statistical methods and what other data sources could we use to navigate those in a better way. The other thing that we have done is looking at mathematical modelling of the impact of opioid agonist treatment as it has been provided in New South Wales over the past 20 years on both fatal opioid overdose and also on suicide. And what this was able to demonstrate is that we have been able to have a 40% reduction in fatal opioid overdose among people engaged with this system over that period, and a 35% reduction in suicides. And both of these things are pretty unique in terms of demonstrating the impact of this system, but also particularly in terms of suicide, a really novel intervention that people don't often think about as a suicide prevention strategy. So just moving on to OATS 2. So basically we have updated the original linkage. So we've now got over 55,000 people who have entered either methadone or buprenorphine since 2001. We've added in new data sets, and so there's both a larger population, longer time period, and a greater number of outcomes that we can examine. And these are some of the questions that we are going to be asking around this. A couple of the ones that I'll draw your attention to is, and particularly given the changes that have occurred over the past 4 years around the provision of long-acting injectable buprenorphine during incarceration, is looking at the impacts of depot buprenorphine during incarceration and post-release, both in terms of risks of mortality and other retention in treatment and other outcomes. Looking at the impact of serious mental illness on engagement with OAT, as well as other mental disorders on engagement with OAT. and looking at other outcomes. So looking at, is there a relationship between entry into treatment and detection of sexually transmitted infections, and how does that pan out in the longer term? And that is being led by Olivia Price. And looking at the perinatal outcomes for women who have a history of opioid dependence, whether or not they enter buprenorphine or methadone, what are their outcomes, and whether or not there's a difference between those two medicines, and that's being led by Danielle Tran. And finally, just to talk about some upcoming work. So we just recently were funded by the NIH to actually extend this internationally. So one of the big narratives that exists in the United States is we can't do data linkage, it's all too hard, and this is not feasible. I mean, the reality is it's very, very hard anywhere. There are issues in the United States with the way that their health systems are organised. But somehow we were able to convince NIDA to give us money to look at 4 of those jurisdictions, as well as Scotland and New South Wales. And Matt Hickman will be talking about some of the work that's been going in Scotland. And the focus of this work is to not only look at the outcomes of OAT on a range of different outcomes in terms of overdose and all-cause mortality, but really extend this in terms of thinking about how do we use these data sets to get better estimates of the prevalence of opioid dependence, which are really crucial in terms of thinking around the extent of the problem and planning, but also using mathematical modelling, which will be led by Natasha Martin, but also involving Jack Stone, who's here today, as well as Peter Vickerman, to look at ways in which we could look at improving the impact of the way in which existing OAT programs are being provided, and what we could do to improve their impact on health outcomes. I think I'm 6 minutes over time, but sorry. I did tell you I was going to go over time. Sorry. Should I just run on stage now? Yeah.
Thank you. I needed a little bell. We will, for the next one, we'll make sure people are using Slido, so if you don't have that number, we'll make sure we share that. But thank you, that was really insightful. We'll move on to the next presentation, which is on the UK supervised heroin treatment trial, Success and Failure to Advance Science, Policy and Practice. And it's brought to us today by Professor Sir John Strang, who's the Director at the National Addiction Centre, King's College London, Academic Lead, Addictions Clinical Academic Group, King's Health Partners, Academic Health Science Centre. Welcome, thank you.
So I wanted to take us to a different type of science. So we've heard about data linkage from Louisa, and it's important to bring the most powerful bits of science we can to the fields that's of concern to us. This is a different type of science to do with looking at randomized trials, but also particularly looking at how do we get lasting impact. I'm in a competition to see how many slides I can get into 20 minutes. So. Lots of declarations. I'm a clinician as well as an academic, and I'm interested in the policy process. And I've worked with governments and industry, and was involved with this particular trial. So these slides will be there so you can look at them in detail. And Louisa, I too can't see a damn thing down there, but, but I think I know the slides okay. And various credits, and I say with apologies to my colleagues that they don't get individual name checks. People can look through it or look through the papers if they're wanting to see it. But it involves extensive collaborations from people from different types of organisations to be able to get a trial like this off the ground. So I'm going to take us quickly through 5 different stages about the heroin trial that we had in the UK and You've had an interesting history about the debate of heroin prescribing or hydromorphone prescribing here in Australia as well. So let's just look at the history around heroin and heroin prescribing. Just for anyone who didn't know about it, heroin is what was a branded pharmaceutical product. We've had heroin as a medication in the UK for more than a century. The US also had heroin as a prescription medicine. I've visited colleagues and done talks in the US where they go, no, we've never had it as a prescription. So you have to sort of show them the fact that at this time you could contact your drug rep in New York to obtain a supply. So in the UK, there was a famous Ralston report in the 1920s which established the legitimacy and the authority of medical prescribing in the name of various forms of treatment, but including the treatment of addiction. And the word maintenance wasn't used then, but essentially this was an endorsement of the fact that if efforts to withdraw somebody from treatment persistently failed, then an ongoing prescribing approach was legitimate medical practice. So it set the UK as separate, in particular, from US policy at that time and subsequently. All was pretty quiet in the UK around the opiate addiction problem or the heroin addiction problem up until the 60s, when, as part of what happened in sort of many parts of the world, part of the youth revolution included the spread of wider involvement with drug use, and in particular in London, but also in some other cities in the UK, there was a socially transmissible increase in involvement with heroin use. And for the first time ever, people in their 20s or even in their teens were being seen involved with heroin use. And initially, the new clinics that were set up took over the role of prescribing injectable heroin as part of treatment. But progressively, there was a sort of disillusionment that crept in that this unmonitored liberal prescribing of heroin wasn't addressing the problem, was creating a secondary black market. And so over the next few decades, we saw a withering of injectable heroin prescribing, not because the law prohibited it, but because the medical profession and the addiction treatment field just concluded it wasn't an appropriate way of managing the situation. And that took us up to a time when it was almost becoming just a historical quirk that had happened, when the Swiss then took the approach and reconceptualized heroin prescribing. And Ambros Uchtenhagen, who sadly died last year, was very much the architect of taking a sort of rusty old concept that the British system had and reconceptualizing it as supervised heroin prescribing, which is what was introduced in Switzerland, subsequently studied extensively observationally. Most of it was observational in Switzerland, but also with a very influential randomized trial from Wim van den Brink in the Netherlands, looking at whether you could engage people who were otherwise failing to derive any benefit from their treatment and actually achieve more engagement and more gains than you were otherwise achieving with that challenging treatment-resistant population. About that time, at the beginning of the century, so it was about 20 years ago, the UK government picked up on this, and in their drug strategy, they identified that heroin should be available on prescription to all those who have a clinical need for it, which is a really powerful statement, although it doesn't actually define how do you work out whether somebody has a clinical need for it. But they also described how it should be provided, that it should be in safe places with careful supervision and monitoring, and attention to prevent seepage into the wider community. So it was a treatment for an entrenched population of people with heroin problems who'd repeatedly failed to derive any benefit from more orthodox treatments. And so the clinics would need to be open 7 days a week, 365 days per year. It was an exciting time, but also quite a challenging time. I remember the meeting talking with staff about how excited I was that we had a new clinic, and there was a general sense of excitement. And then I got to the point that this means we'd be open 7 days a week, and it would also cover Christmas and the New Year, and couldn't quite understand why the level of enthusiasm sort of went down a little bit. But anyway, this was a completely new concept in the UK, and we really wanted to know, would it work in the UK context? We'd seen the Swiss observational work and the Dutch randomized trial, and we set up a randomized trial in the UK. We had a young visitor from Australia who was working with us at the time, and so, Nick Linceris was working with us and very much helped and drove defining the method we were going to use. These slides, as I say, are available, so if anybody wants to see the detail, they can look it up or ask for copies of it. A few quick photos. It's actually not very photogenic. Essentially, we have rooms and we have tables and chairs and things like that, so it doesn't make for good photographs. But the clinic is sort of pretty unremarkable. Somebody's medication would be prepared in advance. It's a high threshold program, so you've assessed somebody, you know what dose is their ordinary dose to be taking, either twice or 3 times per day. We would sometimes be asked by people, do we go down the street to buy the heroin? And you have to explain, no, it's a pharmaceutical drug. It comes from the pharmacy like any other medication. The patient would be called in. The medication would have been prepared, and they would self-administer the drug within the clinic. Most of the photo shots are of colleagues from Australia's had a remarkably high contribution to the work we've done in this area. So when Nick Linceris moved back to Australia, Deborah Zada took over as a consultant, leading on the clinical activity. We were also fairly committed to doing observational research, trying to look at the nature of what we were providing and how did we make decisions about policy and practice. And this was a paper, for example, about whether we would or would not permit groin injecting into the femoral vein, which was quite a common practice in the UK at the time, and was this something we should permit or shouldn't permit? And we then had the main results from the trial, and I'll very quickly take you through those. If you want to see the published version, then here's the Lancet paper, and I don't know how you do this. It's one of my colleagues did it, and I also don't quite know how to stop it either. But anyway, we took just over 120 people. By and large, were defined as people who were causing grief and headache to one's colleagues. Michael, I think, is that a fair description of what the entry criteria were? That colleagues would be saying, we've repeatedly been trying with Joe or whoever, and we can't get anywhere. If you think you're so clever with this new supervised heroin clinic, well, you ever go with Joe. And they would be randomized into either having optimized oral methadone, where we'd pay attention to making sure the dose was right, looking as far as we could at getting better adherence, against the supervised heroin clinic treatment. And in the UK, we had a lot of prescribing of injectable methadone. You actually have a small history of injectable methadone prescribing here in Australia, but it's never really, I think outside the UK, it never became a widespread practice. And so we had a third condition with supervised injectable methadone. And we were wanting to look at, we had lots of arguments about what the primary outcome should be. And we decided that if there wasn't, whatever other gains there might be, if there wasn't a reduction in somebody's street heroin use, then it was actually not causally linked to the actual treatment being provided. And so we were looking for street heroin use, and to begin with, we said it would completely disappear. And then we said, well, actually, we want to be able to capture it if there's been a major improvement that's less than complete abstinence from street heroin. So we were looking for a reduction to less than 50% of the random urine samples that were taken, less than 50, that on most occasions when a test was done, it would be negative for street heroin use. And for those of you who are sort of nodding off and want to know, well, what did we find? Here were the sort of 4 take-home messages, which was the biggest quitting or the biggest reductions in street heroin use were in the group to whom the supervised heroin treatment was being provided. Supervised injectable methadone actually did disappointingly. It wasn't as close to supervised heroin as we'd hoped it would be, but it was still better than the optimized oral methadone group. What was interesting is that the group who was supposedly repeatedly failing in methadone treatment, when we optimized it, we saw improvements with some of those people, but nothing like as much as with the other groups, but also the speed with which that change occurred. So I'll come back to that in a couple of slides. These are the data from the Lancet paper, but I'm going to skip over these and show them to you in a different way. So if we take these 3 groups, so these are randomly assigned people, and at the beginning of treatment, how many are not responding? You know, how many are still having sort of street heroin use every day and are non-responders from our point of view? Now, they haven't started treatment yet, so 100% of them are not responding, which is a relief, because since that's the reason that they're in the trial, it means we selected our patients appropriately. So when we looked at 6 months at how have the different groups performed in terms of whether they've now giving 50% clean urines, so clean is not the appropriate, 50% negative street heroin samples, you can see here that the supervised heroin group, you've got nearly 3/4 of them who are for most of the time giving specimens that are negative for heroin use. Your methadone group, there's 1/4 of those who've made those improvements, and the supervised injectable methadone group's only slightly better than the oral methadone group. But we wanted to go a bit further than that, because people said, well, have they completely quit street heroin use? So we actually thought that was a pretty big ask. But we looked at it, and in fact, you've got here that 1 in 5 of the people in the supervised heroin group, all of their urines were negative. And this is out of 13 random weekly specimens over 3 months. And because I'm a bit of a sort of soft touch when it comes to it, I'd say, well, what if you got most of them clean, but just one slip up? Then you get nearly 40% in your heroin group are giving predominantly clean urines. And because on a really generous day, I might give you 2 slip-ups, then you get more than half of that group are giving mostly clean urines. Another influencer. So James Bell took over the clinic, and this takes us into a different era to do with after the trial ended, we secured support from the government that the clinic should be set up, but this coincided with global austerity and funding cuts, so that severely damaged the commitment. But what we've got here is the speed with which those negative urines were occurring. And you've got that by 4 to 6 weeks, the group in your supervised heroin group Most of those are now giving urine specimens which were negative for street heroin. So whatever changes were occurring were occurring remarkably quickly, and that's been a finding from other groups as well. People wanting to look at cost-benefit analyses. I'm going to skip over this slide, but somebody might ask me to explain it, and I'd say, go away and read the paper if you don't immediately understand it. But the take-home message is, if you're in the bottom right quadrant, rather like Louisa was saying earlier, you've got something that is, that is not only giving you benefit, but getting that more cheaply than other methods. So the failure that I've got in the title is to do with, does that then translate into clinical practice? Does government immediately go, I read your paper in the Lancet, and so we're changing global drug policy accordingly. And austerity was the real kiss of death from this point of view. We had government agreement that there would be a dozen clinics set up around the country to look at the rollout of the treatment. Then cuts came in 2010, 2012, and that was reduced to 4 clinics around the country, then became 3 clinics around the country. But there was that commitment that there should be continuation of the treatment that had been shown to be effective. Our Department of Health put out a call for proposals to set up 3 clinics. We, amongst with others, had to go through a competitive tendering process, and we were successful in being one of the funded clinics. And for the next 3 to 4 years, working with James Bell and others, we then provided this as a treatment within the NHS, so outside the trial setting. And again, this was a second-line treatment beyond the first-line treatment of methadone or buprenorphine maintenance, and achieved remarkable changes with a group who were otherwise appeared to be untreatable. All sorts of issues came up to do with the costs, and I noticed in Louisa's talk about the £3 billion bill to do with the imprisonment of people with addiction problems. People would worry about the treatment costs of £5,000 or £15,000 for supervised heroin treatment, and you then got to remind them that if you look at drug treatment and testing orders or court treatment, you're looking at £10,000 per annum, and prison in the UK is about £50,000 per annum. So suddenly the treatment it needs to be set against that. Finally, after they'd been closed down as part of the cuts when they're put against local services, actually within guidelines about what treatment should be provided, there's a recognition, there's a recognition that there is compelling evidence that it should be provided, so you have a mismatch. You have the guidance drawing attention to the evidence that there is benefit, but at a local level decisions are made that the patient population doesn't deserve such an expensive treatment. And finally, the government then does issue guidance on if the treatment's been provided, here's how the government says the treatment should be provided. So, concluding with 37 seconds left, here's a group that were previously thought to be untreatable, whatever we mean like that, and yet we find it is possible with highly intensive, expensive treatment that requires a lot of effort from clinicians and from the patients themselves to help people turn things around in their lives. There's now a strong, consistent international evidence base from more than half a dozen randomized trials around the world of that benefit. it's costly to deliver, and rather like intensive care wards or special care baby units, there's no escaping the fact that it's expensive to deliver it, but the benefit is cost effective as well as clinically effective. But what stands in the way is the stigma and the persistent institutional discrimination, not just by society, but within treatment services themselves. So thank you very much.
Thank you to Professor Sir John Strang for that. We don't have time for questions because it's really important to make sure that the speakers get as much time as possible. The next presentation is Examining Trends in Drug-Related Deaths, the crucial importance of cohorts in informing our understanding of changing risks and harms. This will be delivered by Professor Matthew Hickman, the Professor of Public Health and Epidemiology at the Bristol Medical School. So welcome.
Thank you very much. Right. So back to cohorts again, as Louisa was highlighting. So, and I put lots of names on there. I borrowed so many slides from my colleagues, which I've just rudely now ignored them. So there they are. There they go. So I hope to again illustrate the benefits of linked data in providing critical evidence on mortality risk and population size, understanding trends in drug-related deaths, but really crucially, as John was suggesting also, motivating and evaluating interventions and policy change, so driving trials or other evaluations. So this was the motivation in Scotland. So the slide on your right, or left, sorry, shows trends in drug-related deaths primarily due to opioid overdose to 2020. So the Scottish government has recognised this as rise in drug-related deaths as a public health emergency. There had been a doubling of deaths in the decade since 2011, a quadruple since 2001, and the rate per million of adults in Scotland aged 15 to 64 at 300 per million. That's 16 times higher than the average in Europe and 4 times higher than England and close to the rate in some areas in North America. The figure on the right is the latest data to 2023, so there's still some slowing, but it is variable, but still very, very high. And it also shows the strong correlation between the rise in opioid overdose deaths and the rise in polydrug use, and in particular, benzodiazepines being detected forensically with opioids, and most of those benzodiazepines were called, the Scottish government calls street benzos because they're not prescribed in primary care. So the Scottish government wanted to commission several studies to address and ultimately reduce drug-related deaths. So we work with Population Health Scotland on understanding the trends, and I apologise about this figure. We're just writing a cohort paper on it, and we will get a better figure sometime. But during COVID, what happened is that in Scottish Public Health, we got drug linkage across all health administrative databases. So prescription data, admission data, laboratory data, mortality data. And from that, we could then extract a drug treatment cohort. So we took people who had been prescribed opioid agonist treatment, methadone or buprenorphine. Then we could link them to assessments at drug clinics, the Scottish Drug Misuse Database, link them to other prescriptions that they might be taking, link it to hospital episode statistics and mortality statistics in a secure data environment. And that was our linked data set that we could then use. So in the flow diagram, shows our data set, there was about 46,000 people prescribed opioid agonist treatment at one time from 2011 to 2020, and over 300 person years follow-up and nearly 7,000 deaths, all-cause deaths and 4,000 opioid-related deaths. So the questions we asked ourselves is really, what could be driving the rise in the number of deaths? Is it because mortality risk is increasing? Is it an aging effect, an age cohort effect? Is the population, underlying population increasing? So is that why the number of deaths are going up? And is opioid agonist treatment protective still at this time of increasing risk of deaths, increasing number of deaths? So this summarizes the data from the cohort study that we published, I think, in the Lancet Public Health. So on the left, on the log scale, is the sort of crude drug mortality rate for the cohort, showing over a 3-fold increase over the 10 years, from 0.6 per 100 person years to 2.1 per 100 person years in 2020, a staggering increase that is the real key driver of why there has been this increase in the number of drug-related deaths in Scotland. On the right is the mortality rate in the cohort for patients on opioid agonist treatment in blue, and for those patients who are out of opioid agonist treatment in red. And there's little evidence of an interaction. But the drug-related death rate increases 3-fold in both populations, in people in treatment in OAT and people outside of in treatment in OAT. And for those out of treatment, by 2020, the risk of death was over 4%, which is the highest, one of the highest published in recent systematic reviews. But those figures also show that being in OAT is strongly protective. Your risk of death was 70% lower if you were in OAT than if you were outside of it, but that wasn't sufficient. OAT wasn't sufficient to reduce the number of drug-related deaths in Scotland over that time. We also looked at age. So although the cohort is aging slightly, drug-related deaths increase with age, but we also observe an increase in the mortality risk over that time for every age group. So although it could make a small contribution to the increase in number of drug-related deaths, it isn't the prime reason. It isn't an aging cohort effect for why there's such a rise in drug-related deaths. So now turn to prevalence. So was the underlying population increasing as well? So there's a backstory to this slide, which is that in many methods of estimating the size of drug user populations, they're not robust and they're at high risk of bias. And Scotland had done capture-recapture methods, but had lost confidence in them and had stopped publishing them. So we came up with a new method, or Haley Jones and I, more Haley to be fair, came up with a method which we call multiple parameter estimation of prevalence, which is a form of multiple parameter evidence synthesis and sort of uses the similar maths to network meta-analysis. And so what we have is we've got a cohort of all the people who we know have been in opioid agonist treatment. And we know the number of events, in this case in our exercise, was drug-related deaths and hospital admissions for opioid overdose. And we know how many of those occurred when people were in treatment or out of treatment. We also know the total number that occurred in the population. So what we can do is we fit, and that's a really loose we, our team fits joint models of the risk of opioid overdose and the risk of fatal overdose and non-fatal overdose out of OAT to the number of additional events that have occurred in the population to then generate the additional number of people who are opioid dependent in the population, and thereby the prevalence of opioids. And there are a number of assumptions which I can go through, but I won't go through actually what I'm saying is that, but the framework that we have is flexible enough that you can bring in additional information that can adjust for those biases, and also the fact that because we're looking at two adverse events, jointly estimating them, that gives us, and that they get prevalence estimates that are coherent, that we think that there's an internal and external validity to these methods. So I'll give you this is the prevalence. This is in Scotland, and that's a sort of similar population than Sydney. It's about 3.5 million people, adults, 15 to 64. And this shows that there's a high number of the known population, that's the bottom line, about 1% of the adult population have at one time being opioid agonist treatment over time. And then our prevalence, we estimated, was about 1.3%, or 47,000 people aged 15 to 64. And there's some weak evidence of a fall in prevalence over the time since 2014-15, which we, as we extend, will see if that continues. But there's no suggestion that the rise in drug-related deaths observed in the population of Scotland is due to an increase in the underlying population. It's all to do with the mortality risk increasing in the population. We can also estimate the number of men and women, and also by age group and also by geographical area using this method. And I just show you this, the last one on aging, that there's some suggestion also that the number of young people is falling who are opioid dependent, and the number of people over 50 is increasing. So again, as I say, as we were going to update this every 2 years, we'll show whether how is this trend changing over time. I'm going to drop that. Because actually we then start to think, well, okay, we know there's an increasing risk in people who are opioid dependent in the population. So what's also driving that? What could be the possible reasons? And Louisa's mentioned this already, that in our earlier cohort studies, we saw that there was a rise in the risk of drug-related death when you left treatment, when your treatment finished or you dropped out of treatment. Both for people on buprenorphine or on methadone. And that led to a hypothesis that the duration of treatment was critical for you to see any population benefit. So the slide on this slide was from old work that we did in primary care populations in England, and we took the mortality rates that we could see in that primary care population of people who were in OAT and not in OAT. And we estimated that to get some population benefit, you had to have a duration of OAT of greater than a year. Louisa's mentioned that we also the team modeled New South Wales, and showing that because in New South Wales, the average duration of treatment was over 1.7 years, and that given that, in the people who were exposed to OAT over about 10, 20 years in New South Wales, it estimated that you averted 40 to 50% of drug-related deaths and nearly a third of all-cause deaths because of that long duration of treatment. And that's only in people given OAT. So we're now going to extend that model to look at the whole population of people who are opioid dependents, both in New South Wales, but also Scotland and elsewhere. So Louisa's mentioned Transform, which is our US-funded study. So we've also got another study funded called Ephesus, which is the same acronym we used before, because we thought, it's similar. We're using the Scottish Link data set. And in Ephesus, which we think our modeler starts in January, led by Jack Stone, what we'll be doing is extending analysis of that linked data set, looking at mortality risk in and out of OAT, across different OATs, across different durations, and then building a model that simulates the population of people who are opioid dependent over time, that population going in and out of opioid agonist treatment, going in and out of prison, in order then to test and evaluate, well, how many drug-related deaths are averted in Scotland with the current program. We extend that model to look at naloxone and say, well, how many of deaths are averted from the national naloxone program? Then we extend that model again to look at variations in those interventions plus additional novel interventions to say, well, how many deaths could be averted by different strategies, and also which is the most cost-effective strategy to reducing drug-related deaths in the population. And similarly, we'll be doing that in looking at OAT in particular in the 4 sites in the US and New South Wales. The other work that's going on is we've motivated by that figure that showed the rise in benzodiazepines. We've got an MRC grant that's also combining qualitative studies with preclinical pharmacological studies, looking at the interaction of benzos and opioids, and some other trials coming. So I'll summarize one of them. This is from colleagues who are doing the preclinical studies. So they've showed and this is in mice. When I say preclinical, it means animals. So in that's showing that benzodiazepines and opioids affect respiration. No, that's not great. That's just to start the experiments. But there might be some suggestion that the way they affect respiration and airflow might be different between benzos and opioids. They haven't told me what it means, how different. They just said it was different, and to not try and explain anything further. We also showed that the effect on airflow, there was a dose-response relationship. So the top figure, this shows a ratio of breathing in to breathing out. And there's this typical thing with people in opioids, as the opioid prescription, when I say thing, this is in mice, when the dose increases, what happens is that they don't breathe in as much. So the ratio changes. And that's different from opioids in orange to benzos. Benzos don't tend to have that same effect, or they have a ceiling effect. And when we look at poly drug use, or when we have mice exposed to both benzos and opioids, what happens is that relationship happens earlier in those with opioids, so that the effect on the airflow for people who are taking benzos and opioids can affect a lower dose of opioids. We've also got some experiments, and they must show that these are not impressed yet and being replicated, that in some experiments, recovery of respiration for mice that have been exposed to benzos and opioids only occurs if they're given both naloxone and flumazenil, so both antagonists to those, which could have quite large implications in harm reduction if it's replicated. And now, I really apologize to qualitative colleagues in the room, because I'm going to summarize a massive study in one slide in about 2 seconds. So at the same time in the qualitative work, there were some in-depth interviews with 48 people who used opioids and benzodiazepines or zopiclone. And the study team found multiple motivations and patterns of co-use, as shown in the figure on the left. And the team classified this into 6 co-use patterns. So co-use to aid sleep or come down, curated co-use with opioid agonist treatment, morning and evening benzodiazepine doses with opioids throughout the day, co-use binges, co-use throughout the day, and then benzodiazepine use throughout the day plus OAT. And as people moved between those categories, there was an acknowledgement that the increase of overdose increased as well. And in particular, the patterns 4 to 6 involve greater polydrug use, less controlled co-use, with a focus often on oblivion, whereas the first 3 was more curated and about anxiety, dealing with anxiety, dealing with sleep deprivation. And again, now the team are now taking these studies and their preclinical studies to try and develop or co-develop more harm reduction messages around co-use. I'm not going to show you this because this is basically epidemiological data from Ephesus showing that there is a risk of well, I will show you, so I'm going to summarize it very quickly. In the epidemiological data in Scotland, unlike in England, what we see is an increased risk of death for people co-prescribed benzodiazepines when they're not in OAT. When they're in treatment in OAT, there's not much difference in mortality risk between people co-prescribed or not. And that's quite important because there's other colleagues Paterson and others have been developing what's called a safer prescribing intervention for giving benzodiazepine in patients in opioid agonist treatment, plus additional psychosocial interventions and harm reduction advice, which in the co-developed studies was acceptable to patients and also healthcare deliverers, and had some signal that it would reduce street benzodiazepine use. So a bit like the Riot trial, but for benzos instead. And this has now led into a trial called the INBOAT randomized control trial, which we're just waiting for confirmation, but hopefully will start next year, which will ask the question, can a sort of diazepam maintenance intervention over 12 months, can it reduce street benzodiazepine use and compared to standard tapering, and can it decrease overdose? And the reason why it's interesting for the link to the Ephesus is that we'll be using the Ephesus model to then evaluate long-term cost effectiveness of this trial. We'll also be using the Ephesus model to evaluate the effectiveness of a new supervised consumption room, which will be opening in Glasgow, hopefully later this year, or maybe early next year. And we've got a new program grant called ENACT, which we'll be evaluating both through looking at the environment, using the linked data to get indicators of reduction in harm in hospital ambulance data and overdose data in the areas surrounded by the facility. And again, the model will then take that forward and say, well, if we, what was it like in Glasgow? And if we increased supervised consumption rooms across Scotland, what impact could we have on drug-related deaths? I'll stop there. Thanks very much. So sorry. It's all Louisa's fault for going over.
Thanks, Professor Hickman. That was really useful, some great data there. Our next presenter is Dr. Thomas Santo Jr, a postdoctoral fellow at NDARC and University of New South Wales, presenting on global coverage of interventions to prevent and manage injecting drug use-related harms in prisons, a systematic review. Welcome.
Thank you, Carolyn, for the introduction, and good morning, everyone, and good afternoon and good evening to those tuning in from overseas. My dad insisted he get the link to be able to watch. So my name is Tom Santo, and I'm a postdoctoral research fellow at NDARC, and today I'm going to be presenting on the importance of healthcare interventions, but really the coverage of healthcare interventions related to HIV, hepatitis C, and injecting drug use and related harms globally. Sorry. I'd like to begin by acknowledging the Gadigal people of the Eora Nation, who are the traditional owners of the land we're gathering on today, and also the Bedigal people, who are the traditional owners of the land which we did most of this work. I'd also like to pay my respects to elders, both past and present, and finally acknowledge the unacceptably high rates of incarceration among First Nations people globally, and including in Australia. First off, also, I'd like to thank the Global Reviews team. This is a massive amount of work, and we wouldn't be able to have done it so efficiently without them. And also like to thank many of our collaborators, including people, Jason Garbley and those from the Kirby Institute, and acknowledge the funding as well in relation to the Ascend grant that helped us get going. Also like to thank the many people who gave us information to help us complete the information side of this review. So some background, Louisa and some of our colleagues through the Global Reviews team did a series of reviews on the prevalence of injecting drug use in the community and the prevalence of HIV and hepatitis C among people who inject drugs. And the most recent version of those reviews were published in Lancet Global Health in 2023. And so the figure on the right is a image of the coverage of OAT, which is opioid agonist treatment, or methadone and buprenorphine for opioid dependence, and then NSPs, which is needle syringe programs for people who inject drugs globally in the community. So prisons were excluded for a number of methodological reasons from the previous reviews, and are a different way of analyzing and also looking at or finding the data that is necessary for the coverage reviews is also the prevalence reviews as well. So the figure on the right, again, was the coverage part of the review, which is the arm of the review which I'm presenting on today. And it's critical that we look at the coverage of interventions related to bloodborne virus disease and injecting drug use in prison, given that we know that there's a range of shared risk factors for prison as well as bloodborne virus disease and injecting that, like socioeconomic disadvantage, that increase the risk. And we know that from smaller surveys as well as previous global reviews of bloodborne virus disease in prison that there's a elevated risk. However, we don't have country-specific estimates for the prevalence of injecting as well as the prevalence of bloodborne virus disease in prison, nor the coverage of interventions like NSPs, OAT, and HIV testing and treatment, and as well as hepatitis C testing and treatment for prisons. Until now, I suppose. So the first part of the review, we estimated the prevalence of lifetime injecting among people in prisons globally, and we found that there was a prevalence of around 10%. The light orange here shows countries that were in between 10 to 30%, and the beige are between 2 to 10%, and we can see Australia in orange. Those are the 30% or higher countries, and Australia was actually one of the highest with about 50% lifetime history of injecting among people who are incarcerated. Here's some more numbers related to that. We have estimates related for each region, and then estimates for men and women. Again, the total number, 10%, quite similar between men and women, and it means that about 1 in 10 people who are in prison have a history of injecting drug use. The next column. So here we're looking at the rates of imprisonment globally as well as the number of total prisoners, and looking at a comparison of the prevalence in prison to the prevalence in the community. So, for example, in Australasia, it's about 80 times higher, the prevalence of injecting drug use in prison than in the community, and 28 times for hepatitis C and 0.4 for HIV. We have a range of variable data availability for those, but we'll also see that reflected in the coverage arm of the review. But we have pretty well overall estimates as far as each of the regions. So the methods for the coverage arm of the review, so we looked over the peer-reviewed literature, which is many of the normal databases that you would search for when you're doing a typical systematic review, but also a major gray literature search was done, because a lot of the information that we search for is published through government reports or reports from NGOs or things like that, and then also a lot of it's not published as well, and so working with international organizations as well as contacting experts from each country is critical to kind of getting a full picture of what's going on globally. So this shows what we found. So it was, again, a massive review, and again, thank you to our team, because we identified about 45,000 studies through Medlane, MBase, and PsycInfo. Gray literature, there were about 25,000 documents, and a range more from other sources. We ended up in identifying 2,630 documents that were eligible for the review, so they had information we could have included, but for our review, we were only interested, I guess, in the coverage arm of the review, in the information of the most late the most late or most current information as far as whether or not a country is in providing an intervention like NSPs, OAT, testing or treatment for blood-borne virus disease. So what we found, just a quick overview, and I'll continue to talk about these numbers throughout, about 37% of countries with HIV available data on HIV testing and similar numbers for HIV treatment, and slightly lower for hepatitis C. We found more data for opioid agonist treatment in NSPs, and we'll see the reason for that in a moment, but it's mainly because we have a lot of no's there, and as opposed to HIV testing and treatment where the lack of data or the no's weren't, the lack of data was higher than the amount of no's we had for those services. So in here we have the overall coverage of OAT globally, so that's methadone and buprenorphine for opioid dependence, and only 55 countries, so a quarter of the world's countries, had at least one prison in their country that had OAT, and fewer, about 18 or 12%, offered OAT in every prison within that country. In Central Asia, about 40% of the countries in at least one prison, Eastern Europe with 12% in every prison and 71% in at least one, so you can see some more greens in that area. And then in Western Europe, you see a lot more blues, which has the highest rate of, or highest number of countries with coverage. So about 62% with, or sorry, 79% with at least one prison in their country that have opioid agonist treatment, and more than half had OAT programs in all of their prisons. For needle syringe programs, so in the gray, lack of data, orange or red, not available in prisons, and then blue is available in all prisons, and, or sorry, green is available in all prisons, and then blue is available in at least one prison. So we can see there's only one country globally that had NSP in all prisons, which is Iran, and we're also seeing North America, so Canada, as well as some countries in Western Europe offering needle syringe programs in prison, so quite low. And that was 11 countries overall. Well, HIV testing and treatment availability, we have in the green both HIV and testing treatment is available. In the blue, we found evidence of testing, but not treatment. Light blue was, I believe, or was testing but no treatment. And, sorry, dark blue is treatment but not available data on testing. And this is, again, what we could find through the literature, and 69% of countries, sorry. We'll look at those numbers in a moment, a little bit of a error on the slides. So, cool. HCV testing and treatment, 27% of countries had available data on testing and 23 on available data on treatment. And similar to the previous slides, hepatitis C treatment and testing more available in data, more data available, at least in North America, Western Europe, and Australasia, and a lot of countries with a lack of data here. We can see through the gray. So overall, we found that this is one of the main findings, at least for NSPs and OAT, is that there's far more programs in the community compared to prisons. So interestingly, there's more needle syringe programs, or more countries with needle syringe programs globally, so about 45%. Of countries, but then what drops down to 11 countries overall, or 5%, which there were some countries there. The error on the slide is due to the fact that some countries had them and more recently removed them. 43% of countries with at least one OAT program, and then down to a quarter for prisons. So from the main findings is we found that blood-borne virus disease and injecting drug use is far higher in prisons, but the treatment and intervention availability is far lower. And so the availability of services is extremely low, and the service coverage is far more widely available in the community than in prisons. And there was a wide range of estimates and data availability across regions, again with the Western Europe, North America, and Australasia having more data that we could find compared to some other regions. Some limitations, again, the availability of data, far less than the community, and the programmatic data as far as the number of needles distributed as well as the number of people in OAT. That graph that I showed at the beginning with from the previous reviews with the circles and the number of OAT and NSP programs in the community relative to their prevalence of people who inject drugs, we weren't able to synthesize data in that way to find out, how many needles are being distributed in relative to the number of people in prison or the number of people who inject drugs in prison, just because there wasn't enough data on that. And again, with only 11 countries providing the service, that's not too surprising. There's also a kind of disaggregated nature of prison data, just as far as the numbers of countries that would report the number of facilities that had a service versus the number of individuals on a service, and then even different types of prisons, or most prisons also being all men or all women. So some next steps. So given the amount of studies that we screened throughout the whole process for these reviews, we're not just stopping at the prevalence estimates and the coverage reviews, so we'll look at a range of different other outcomes. We're looking at tuberculosis and hepatitis B prevalence, as well as the availability of testing and treatment for those interventions, and then also looking at things like naloxone distribution and other coverage types of interventions in prison. So in conclusion, there's a major need for increasing our availability of services for people who inject drugs, as well as people with bloodborne virus diseases generally in prisons. And when comparing opioid agonist treatment and NSPs to the community, as well as the availability of bloodborne virus treatment and testing, the coverage of those interventions is staggeringly low compared to prisons. And if we're going to abide by the kind of treaties set out and agreements as far as healthcare being a human right, and us making available the same level of healthcare treatment for people who are in prison versus the community, then it's critical that we expand these services and ensure that people are getting the treatment and other interventions and testings that they need. And I will try to catch up. Cool. Thank you.
Thank you for that. Our final presentation in this session is brought to us by Dr. Chrianna Bharat, postdoctoral fellow and applied biostatistician of NDARC, the University of New South Wales, exploring the development of opioid use disorder following treatment with opioid analgesics with non-cancer for non-cancer pain relief. Sorry, I've got that all wrong. An Australian statewide nested case control study. So thank you.
I appreciate that I am standing between us and coffee, so I will do my best to get through this. I'd like to start by first flagging that this is a work in progress and pending peer review, so very excited to share these initial findings with you, but appreciate if they are not shared beyond this presentation. I'd also like to thank all of the co-authors on this project who are listed on the screen, as well as the various other people who have been involved in the POPI2 project in the years and made all of this possible. So, as the previous speakers have outlined and very nicely set up, we know that opioid use disorder is a profound and pervasive public health issue. And it has, in part, in certain settings, been impacted by an evolving landscape of opioid prescribing practices. So opioids are a crucial part of medicine, playing a particularly important role in pain management. However, the use of opioids puts patients at risk for extramedical use. So that's where you're using the opioids in a way that wasn't prescribed by your doctor. And we know that that also can put you at an increased risk for a range of adverse outcomes, such as fatal and non-fatal overdose, and also the development of opioid use disorder. With an increase in exposure to prescription opioids over time, we've also seen an increase in population-level rates of harm. So in recent years, hospitalizations and deaths attributed to pharmaceutical opioids have outnumbered those related to illicit opioids. And so while we've been looking this morning so far to sort of the treatment of opioid use disorder, we're now taking a step back and looking at what are the factors that impact risk of opioid use disorder, and in particular, what are the patterns of prescribed opioid use that are associated with an increased risk of opioid use disorder. So the POPI2 project is a cohort of all adult New South Wales residents who over a 15-year period were initiated a prescribed opioid. We identified these dispensings through the PBS, the Pharmaceutical Benefits Scheme, and from this we were able to link to other dispensings for other medicines. We had records for death notifications as well as cancer notifications, and we also linked these data to health service use. So opioid agonist treatment, hospitalizations, ED presentations, and also community-based mental health treatment. And for the purpose of this study, we defined opioid use based on presentation to a hospital where there was a relevant diagnosis code or the initiation of opioid agonist treatment. We use a nested case control design for this study, and I'll go into a little bit of detail about what that looks like. But from the entire POPI2 cohort, we excluded people who had a history of cancer or palliative care based on their differential risk-benefit profile. And that provided us with an eligible cohort of nearly 2.5 million people who, at the initiation of their prescribed opioid, had no history of opioid use disorder. From those 2.5 million people, there was a total of just under 12,000 people, or 0.5% of that cohort, who had an onset of opioid use disorder during follow-up, with a median time to onset of that disorder of approximately 4 years. So we identified all cases, and then we matched those cases to 8 controls based on sex, age, and cohort entry date. So this controls for calendar time. So here's a little diagram that I think really nicely demonstrates this study design. So we have entry into the cohort, which is we define as opioid initiation, and then we have the index date, which I'll define in a second. So we have the exclusions that I just mentioned, and then the requirement that they had a year of PBS data available to be able to define them as a new opioid initiation. We have follow-up from cohort entry to either end of follow-up of our data, death, or where there was evidence of cancer or palliative care during follow-up, we then censored them at that date. Our cases were assessed as people who during follow-up had a first onset of opioid use disorder, and the date of that onset is defined as the index date. Thinking back to the matching of controls that I mentioned, we assessed for each case the controls that met criteria for matching, which in this case meant that they had no evidence of an OUD by that index date. This is important to clarify because cases can be controls prior to their index date, and controls or individuals can be controls for more than one case. So once we've identified our cases, we've got our index date, and then we've matched them to controls. We assessed relevant covariates at baseline, including defining from hospital records the 5-year history of Charleston Comorbidity Index and evidence of other relevant medical conditions. And then for the aspect or metric of interest, we were looking at exposure to opioids. And we defined this using our published method for defining time on and off medicines from Australian dispensing data. And we defined opioids exposure in a number of ways. And we'll dive into that in a little bit. But just to mention that they are binary measures, so yes, no, and then also dose-specific measures, so looking at oral morphine equivalent exposure levels. And we did this over a range of different intervals. So looking at the index date and looking back to assess exposure in various windows. Quickly characterising the baseline characteristics of cases. So of that 11,800 people, 40% were female. They had a median age of 29 years at cohort entry, and they were similar to the controls in terms of their regionality and also socioeconomic disadvantage. Cases, however, were individuals who had higher comorbidity indexes in the 5 years prior to cohort entry, as well as higher rates of health service use for a range of relevant conditions shown there. That is a big, messy table. We'll break it down. So looking at the binary measures of exposure, we've got here 3. So that is any exposure to opioids during a specified interval, exposure to any strong opioids, and then we also looked at defining long-term exposure, which we classified as 90 days of continuous opioid use. So, as I mentioned, we did this over various intervals, and this was largely because the mechanisms by which opioid exposure, prescribed opioid exposure, impact opioid use disorder risk remain still not well understood. So what we wanted to do by specifying these different time intervals is understand what types of exposure, but also the recency of that exposure and how that impacts the risk of opioid use disorder. We found for all of these metrics that the exposure was higher among cases versus controls. So that's looking between metrics. If we look to want to compare those, we'll use the AIC, and this allows us to look at how well the model fits the data provided. And we can see that for smaller values being better, the exposure to strong opioids was the best model fit. So looking within that metric, we can then compare the different intervals, and we find that exposure to strong opioids in the 90 days prior to index date was the best model fit for in terms of predicting opioid use disorder. And in this case, it was associated with a 10-fold increased risk of onset. When we use this approach across the various binary metrics, we see that there is variation in the intervals of time that best explained the model. Looking at the OME or the dose-specific models, we considered peak estimated daily OME. So for the intervals that we've got there, 0, 28, 90, 182, and 365, within those intervals, we looked at on any given day what was the maximum dose they were prescribed. And in that case, we found that the 28-day interval was the best model fit. We're going to come back to these results to compare them in a moment. The other dose-specific model was the average estimated daily OME. So if we consider the interval and that there'll be variation in the dose over time, instead of looking at the max, we took the average over that interval. And in that case, it was the 90 days interval looking back that was the best model fit. So let's pull all of those together. Summary of best model fits. We can see that for all of the associations considered, there was an increased risk associated with opioid exposure on the onset of opioid use disorder. That varied based on how exposure was defined, it varied based on the time windows that were assessed, and then it also varied based on the characteristics of the exposure that we considered. So to just pull all of that together, we found that more recent opioid exposure was associated with increased risk, especially when you were exposed to strong opioids. We found that higher doses increased risk, and particularly when those high doses were maintained over a period of time. Important considerations, it was a whole of population capture with extended follow-up, and our study design mitigated a lot of common biases in these types of analyses. However, we are conscious Given that this is administrative data, the comorbidities will be underestimated, and more importantly, the outcome is defined by entry into treatment. So the symptoms will likely have manifested some period of time prior to the index date that we have identified. So that is an important consideration in interpreting these results. Implications. There is a lot that we can do and will be doing in investigating how these associations vary, potentially based on time since initiation of the opioids, as well as other characteristics of exposure, characteristics of opioids, as well as other medicines that might have been used at that time. I did my best to shorten it down. Thank you so much. Appreciate your findings.
Thank you. You saved us definitely a few minutes there. Can't take away from everyone's morning tea. But a huge thank you to all of our presenters this morning. There was such a breadth of knowledge and research, and just looking at targeted population-wide effects of treatments, system costs, impacts on the broader health systems and costs of society. You know, research and trials will really inform and help shape future treatments and policy as well, and really appreciate just the work and look forward to seeing some of the work as it progresses as well. I won't hold everyone up from coffee and morning tea, so we are going to have a break now for 20 minutes for morning tea, and then we'll be back here just after 11 o'clock for the next session. So we'll see you all then.